Greeting to all the PhysioTV viewers. I am Dr. Barkha Nathani, final year postgraduate from Sancheti Institute for Orthopaedics and Rehabilitation, College of Physiotherapy, and moderator for today's session. Our topic for today's PhysioTV session is on clinical prediction rules by Dr. Sibi Joseph. Sir, it gives me an immense pleasure to welcome you. Sir is a professor and HOD in the Department of Musculoskeletal Physiotherapy at Lokmanya Tilak College of Physiotherapy, Kharghar, Navi Mumbai. He has done his graduation and post-graduation in orthopedics and with manual therapy as his elective from Manipal University. He has completed his PhD in physiotherapy from MGM Institute of Health Sciences, Navi Mumbai. He has more than 14 years of his teaching experiences and has participated in various international conferences like Global Spine Congress 2019, IFO MPT 2016, Glasgow, Low Back Pain Congress Dubai 2013, Toronto, and many more. Consequently, for 2 years, he has awarded the best paper in senior category at the International Conference of Physical Therapy at AIMS Delhi in year 2016 and 2017. He has numerical publications to his credit and also a viewer of two international journals in physiotherapy. He has a special interest in the area of spine and is currently working on a project in a collaboration with University of Latrobe, Australia. He is an academician, clinician, and researcher. Sir, it gives me an immense pleasure and we welcome you for today's talk. And now I will hand over the session to you. Over to you, sir.
Thank you, Barkha, for the wonderful introduction. Good morning to all of you. My topic for today is clinical prediction rules in musculoskeletal rehabilitation. At the outset, let me ask you all, how many of you all have heard this terminology, clinical prediction rules or CPRs? If not, by the end of this session, I'm sure you're going to get a fair idea about CPRs or clinical prediction rules. So by the end of this talk, you all should be able to identify the role of clinical prediction rules in evidence-based practice. You all should be able to identify the steps required to formulate clinical prediction rules. You should understand how to identify their readiness for application in clinical practice. And finally, you all will be able to understand the clinical applications of clinical prediction rules in musculoskeletal rehabilitation. So let's assume a hypothetical situation. A patient walks into a clinic with shoulder pain after he had an injury due to some overstretching during his gym workouts. So now, tell me, how will you diagnose this case? How would you establish the prognosis of the outcome of this patient? And how will you implement the interventions suitable for this patient? So let me ask you, when this patient comes to you, will you send this patient for an X-ray? Or would you like to send any patient walking into clinic with an acute shoulder injury, acute ankle injury, acute knee injury for X-ray immediately? Or how can you decide which patients require an X-ray? So now this requires a lot of clinical reasoning. You might tell me it depends on your experience. If you're a novice therapist, you may send the patient for X-ray. If you're more experienced, you may not send. But then this is very subjective, right? So here you need something more concrete to decide which patients can be sent for an X-ray or MRI, which will make you more confident in making decisions. So imagine this patient comes with a reference from orthopedic surgeon. So he's been to orthopedic surgeon first, and the surgeon immediately referred for an X-ray. So you need to understand whether every patient needs to be sent for imaging. Imagine it would have been so much better if we had a CPR or clinical prediction rule, which is used to differentiate which patients presenting with shoulder pain required an X-ray, with fracture being the diagnosis of interest. Usually, X-rays you send to find out fractures, right? What if we had a CPR predicting the outcome of the condition? What if we had a CPR which tells you which intervention would be the best for this particular patient and will benefit the patient? Now, for all these things, you have something called as evidence-based practice. I'm sure you all are familiar with what is evidence-based practice. So evidence-based practice is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients or clients. Now, this EBP requires decisions about healthcare based on the best available, current, valid, and relevant evidence. I'm sure you all are aware of the various levels of evidences. At the top of the pyramid, we have systematic reviews of RCTs. Then we have individual RCTs. Then you have systematic review of cohort studies. Then next, you have individual cohort studies. And then you have systematic reviews of case control studies. Then individual case control study. At the fourth category, we have case series. And finally, we have the expert opinion. Right? So any literature you read or any research you do, what is your ultimate aim? Your goal should be to translate the research finding into clinical practice. So in the knowledge to action cycle, the knowledge creation funnel starts with individual research studies and is then distilled down into synthesis of the best quality studies, which are then used to develop evidence-based tools and products. Knowledge synthesis, such as systematic reviews and meta-analysis, are evidence-based research summaries that can reduce the burden of evidence-based practice on clinicians by taking on the effort of searching in a methodical fashion for the best quality evidence and synthesizing it into summary recommendations. Now, these systematic reviews and meta-analysis are highly valued by clinicians because they are able to bring together a large body of evidence on a clinical topic. And this saves tremendous amount of time that would otherwise be involved in independently searching for and evaluating primary studies. However, one of the challenges we face with evidence-based practitioners when attempting to use these synthesis is that these recommendations or conclusions may not be sufficiently detailed to facilitate implementation in their practice. So there are various tools which deals with that transition from evidence synthesis to clinical tools and products that may help clinicians move evidence synthesis into action. So the various tools currently available are your clinical practice guidelines, CPGs, algorithms, clinical prediction rules, clinical pathways, and patient decision aids. So out of all these, today we're going to focus mainly on clinical prediction rules. Now, what are CPRs? CPRs or clinical prediction rules, also known as clinical decision tools, are evidence-based tools that quantify the contributions of relevant patient characteristics and clinical findings to provide numeric indices that assist clinicians in making decisions about diagnosis or predictions about treatment response or outcome. In a prediction rule study, investigators identify a cohort of patients and measure suspected diagnostic or prognostic indicators and then determine the outcome. Statistical analysis are used to determine which of the possible diagnostic or prognostic indicators have clinical utility. Statistical prediction tools use statistical analysis of prior cases with known outcomes to identify the quantified relationship between predictor variables and a particular diagnosis or outcome, such that they may be used to make future predictions. In contemporary healthcare practice, the application of statistics facilitates the transformation of data into evidence-based diagnostic, prognostic, and treatment decisions. So basically, you have CPRs to diagnose a case, to predict the future outcomes, and to find out the best intervention possible. So, with regards to all other tools, CPRs also have their own advantages and limitations. A notable advantage of statistical prediction tools over unassisted clinical judgment is the control of human cognitive biases. So it is very subjective. So if it is if you are based with clinical judgment, or if you rely too much on your clinical judgment skills, it's very subjective and it's going to vary from person to person. But whereas if you have a CPR, so everybody will do the same thing. So it is more objective in nature. But a critical limitation of statistical prediction tools is the inherent inflexibility and fragility. It's very rigid. You cannot change the rules. And CPRs are not able to inform all categories of clinical judgments. You may not find a CPR for every clinical condition. That is one disadvantage or limitation. And they are also not able to integrate all of the available information. The use of statistical procedures to inform decisions is therefore crucially reliant on a skilled individual's ability to judge the appropriateness of its application and awareness of its limitations and assumptions and the accurate interpretations of its results. So even if you're using a CPR, you should be able to judge how appropriate would be this particular CPR for a particular condition. You should always be aware of its limitation and assumptions, and you should also be able to accurately interpret the results. That is very important. CPRs are commonly used to describe the likelihood of the presence or absence of a condition, assist in determining patient prognosis, help in the classification of patients for treatment. They usually compose of variables obtained from the history, physical examination, and simple diagnostic tests that show strong predictive value. PE has given this prediction model. So prediction model may normally perform well under usual circumstances. Human adjustment in the light of additional information not accounted for in the model that will influence the predicted outcome. For an analogy, you have this broken leg countervailing theory, which says that, now, for example, if you um, want to predict the outcome of a movie, for example, if a new movie is released on a Friday, you have these trade analysts who basically try to predict the attendance of the moviegoers over the weekend or over the next 1 week. So this will be valid if everything else is constant. There is no unforeseen things happening. Then whatever you predict will come true. Now, for example, if somebody meets with an accident, so definitely you cannot expect that person to be in the movies, right? Or if there is heavy rains, the weather is not pleasant. So on that particular day, your prediction will not be true. So uh, that is how prediction models work. If everything is favorable, the circumstances are favorable, prediction models will work. Otherwise, whatever you predict may not come true. Statistics are not always available to inform all categories of clinical judgment, limiting the applicability of statistical prediction tools. Greater awareness of common cognitive errors and strategies to reduce some errors may assist in minimizing errors of clinical judgment. Clinicians using statistical prediction models integrate the objective data produced from such tools with all other existing information to facilitate their decision making. Statistical predictions do not form a clinical decision, but instead inform a clinical decision. Now, CPR should be differentiated by their purpose into three distinct subgroups. One is a diagnostic CPR. Next, we have the prognostic CPR. Then we have the prescriptive CPRs. Diagnostic, prognostic, and prescriptive. CPRs of all three types are becoming increasingly prevalent in rehabilitation. CPRs that focus on factors that differentiate patients with a specific diagnosis are known as diagnostic CPRs. CPRs that identify factors that can predict future outcomes such as treatment success or return to work are considered prognostic. CPRs designed to target the most effective interventions based on presenting criteria are prescriptive CPRs. One of the most well-known and most commonly implemented diagnostic CPR is the Ottawa ankle rules. This is the best example of a diagnostic CPR. For the prognostic CPR, you have CPRs to predict ambulation following spinal cord injury. You have prescriptive CPRs, which describe patients who would respond to better interventions for back pain. For example, you have something called as treatment-based classification. So that is a kind of CPR which is used to subgroup the patients in different categories to identify which intervention will benefit which type of patient. An example of the diagnostic CPR is the Ottawa League Rule. So this is basically a 5-item tool designed to help inform decisions regarding which patients presenting to an emergency department following an acute knee injury require an X-ray. So a patient's status on the CPR is determined by considering the presence or absence of 5 clinical variables. So in the absence of all 5 clinical variables, the likelihood of a knee fracture is remote, and consequently, an X-ray of the knee is unlikely to yield valuable clinical information. Which means, if a patient walks in with an acute knee injury, we try to apply Ottawa knee rules, and if you find all the 5 criteria are not met, then definitely you can be sure that the patient does not require an X-ray because you're not suspecting a fracture. So here you can be 100% sure. Next, for an example of Cassandra rule, you have um, prognostic CPRs. The best example is Cassandra rule. So this is derived from the population of patients with back pain presenting to primary care physicians and aims to identify individuals with differing degrees of risk of developing long-term significant functional limitations. So prognostic CPRs differ from the diagnostic counterparts with respect to their dependence on the dimension of time. So these CPRs will function to inform clinical judgments regarding future outcomes. So they will predict the future outcome. So in this case, it will tell you how many patients with back pain will develop long-term significant functional limitations. So this is the Cassandra rule, basically. Next, we have prescriptive CPRs, and these have been used to describe which patients who would respond to different interventions, for example, neck and back pain. So prescriptive CPRs are basically used to find out which would be the best intervention for a particular condition. Prescriptive CPRs are the third major type of these tools and function to subclassify patient populations by matching patients to treatments based on their predicted responsiveness to that treatment, independent of a diagnostic classification. So the best example I gave you is treatment-based classification, in which you classify back pain patients into different types of treatment, like which patients will benefit from manipulation or mobilization, which patients would need traction, which patients would need a direction preference exercises or specific exercises, and which patients would require stabilization. So once you subgroup the patients, classify the patients, you can decide which treatment will benefit which type of patients. So that is the best example of a prescriptive CPR. Prescriptive CPRs inform clinical decisions regarding treatment selection and can be conceptualized as a special form of prognostic CPR that specifically relates to treatment effects. The example I told you is treatment-based classifications for low back pain. So now we all have learned what is CPR. You have a fair idea about CPRs and what are the different types of CPR. Now, next, you need to understand the different stages in the development of a CPR. Here you have the derivation, narrow validation, broad validation, and impact analysis. The first step in the development of a CPR is derivation. This process commences with the identification of a meaningful problem for which the development of a CPR may be perceived as clinically useful. CPRs can be graded on a scale from 1 to 4 depending on where they are on the developmental continuum, with level 1 indicating the highest stage of development and level 4 indicating the lowest. So based on the stages in the development, you have to grade from 1 to 4. I repeat the 4 stages. Derivation is the first stage. Then you have narrow validation, broad validation, and lastly, impact analysis. So in the derivation stage, you identify a meaningful problem. Considerations that help inform the need of a CPR include the complexity of clinical decision making, accuracy of unassisted clinical judgment, clinician attitudes, variation in practices, and the hypothesized potential for a tool to beneficially impact practice by improving patient outcomes or improving resource efficiencies. So derivation is the stage where the CPR is first proposed and tested on at initial data set. Those CPRs that have been derived but have yet to undergo validation or impact analysis are considered level 4. So level 4 CPRs complete only the first stage, that is derivation. The first stage of validation would involve testing the CPR in a similar independent sample and then proceed to broader patient samples. The progression from a level 4 to level 3 CPR includes validation of the original variable set in a narrow population. CPRs that have been validated in broad populations, and if the CPR can be demonstrated to be generalizable to other patients, they can be considered to have reached level 2. These rules can be applied confidently in clinical care as they have demonstrated stability in their predictive ability across diverse populations. So, in simple terms, if a CPR crosses only one stage, that is derivation, you grade them as level 4. If a CPR has completed derivation and narrow validation, you grade them as grade 3. If a CPR has completed the first 3 stages, that is derivation, narrow validation, and broad validation, you can confidently grade them as level 2. The highest level of validation is level 1 and occurs when CPRs have undergone an impact analysis that demonstrates positive effects on clinician behaviors, outcomes, and cost effectiveness of care. You can grade a CPR as level 1 only if the CPR has completed all the four stages, that is derivation, narrow validation, broad validation, and lastly, the impact analysis. For example, the Ottawa ankle rules have been shown to decrease utilization of radiographs without resulting in missed fractures and provide a mechanism for patients to self-assess their need for emergency treatment. So Ottawa ankle rule is a very useful CPR. So based on that, you can decide any patient working in with acute ankle injury, does he need a X-ray or radiograph? So radiographs, sending every patient for radiograph is not a good practice because it's a lot of waste of time, waiting time is involved, waste of resources, and at the same time, unnecessary exposure to radiation, which is not good for the patient. So very judiciously, you need to um, decide which patients to be sent for imaging. CPRs that reach level 1 validation can be used in a wide array of settings with confidence that their use will be beneficial. At present, few CPRs have reached the level 1 validation they should have before considered appropriate for widespread implementation. So therapists should consider CPRs carefully, evaluating the quality of the development and the extent that they could be generalized to their patient population before implementing them. So in literature, you'll find a lot of CPRs, but selecting them depends on the therapist. You should be very careful when you select a CPR. First thing what you need to know is the quality of the development. You need to know what level is the CPR. Level 1 CPRs, level 2 CPRs are very good. Confidently, you can apply them to clinical practice. And at the same time, you need to use the clinical skills, clinical reasoning to understand whether the CPR can be implemented to the population you are seeing. Now, when you derive a CPR, the study designs are going to be quite different for different types of CPR. For a diagnostic CPR, we use more of cross-sectional studies. For a prognostic CPR, we use more like a longitudinal cohort studies. For a prescriptive CPR, we go for randomized controlled trials. Next, we have the readiness for application in clinical practice. The stage of a CPR's development has direct implication for its readiness to be applied in clinical practice. This is due to the structured process of a CPR's development, enabling progressively greater confidence in the tool's accuracy and generalizability. Mackin et al. Proposed a hierarchical framework to determine the degree to which a CPR may be used to confidently inform clinical decisions based on its stage of development. CPRs that have been derived but have not yet undergone validation are not considered within this framework to be ready to be applied in clinical practice. So if it is a level 4 CPRs, definitely you cannot apply them in clinical practice. CPRs that have undergone narrow validation may be cautiously applied with some confidence in their predictive accuracy in the limited instances where a clinician's caseload closely approximates that of the validation and derivation studies. Level 2 CPRs can be applied, or level 3 CPRs can be applied. Level 2 CPRs can be applied, but be very, very careful. Application of a CPR at this stage of development, even with this limited context, may not necessarily result in improved patient outcomes or other improvements in clinical care. CPRs that have undergone broad validation may be applied with some confidence in their predictive accuracy across various clinical settings. This stage of CPR development does not, however, provide evidence that the use of a CPR will have beneficial clinical consequences. CPRs that have undergone impact analysis may be applied with confidence that their application in clinical practice is likely to result in improved patient outcomes or resource efficiencies while maintaining quality of care and patient satisfaction. So if you come across any CPR which has undergone all the four stages, you can very confidently apply them into your clinical practice. At the present time, however, very few CPRs relevant to musculoskeletal practice have undergone this necessary phase of development. So there are very few CPRs which has undergone impact analysis.
So thank you. And here we stop for today with part 1 of brief introduction about CPR, the advantages and limitations, uses, the three subgroups which are diagnostic, prognostic and prescriptive in development of CPR. So stay tuned for the next part tomorrow. Thank you to all the PhysioTV team and have a great day.